We'll talk about the new technologies of knee replacement of knee arthroplasty, the advantage, disadvantage, and the outcome. Also, we have to discuss about the advantage and disadvantage regarding the simultaneously bilateral knee replacement in Saudi German hospital as your experience in this field. Also, we have some discussion about the the diagnosis of the and management of the pathological fractures of long bone with the common cause of the pathological fracture, differentiation between the and the traumatic between the traumatic and the pathological fracture, diagnostic pathway in the pathological fractures, and recent trade in management. We have also will discuss about the scoliosis and adolescence, the progression, what's the meaning of the scoliosis, the consequences, and the care for prevention, indication, and follow-up. First, we'll start with Dr. Walid Shafi. He will talk about the new technology in the knee arthroplasty. Now, Dr. Walid Shafi is a orthopedic consultant in arthroplasty, head of department Saudi German Hospital Azir. We start now with Dr. Walid. Dr. Walid, you have 30 minutes.
Okay, thank you so much, Dr. Marwan. And also I'm welcoming all audience and thank you for all my colleagues, Dr. Hani and Dr. Walid Hamid. Today I choose to talk about the new technologies for the knee arthroplasty. Uh, we will talk about the computer-assisted total knee replacement, which allow the surgeon to plan and perform a femoral and tibial bone cuts in very precise fashion and have been supported by many reports in the literature. There is three types and all systems or types rely on some type of signaling technology that allows surgical instrumentation to be positioned in the desired position for bone cuts. Signaling options include infrared and electromagnetic signaling, and some system required pre-operative three-dimensional image like CT scan or MRI, and other used intraoperative imaging, and some imageless system. Imageless technique has tend to be the most frequented used now, and because there is no need for using a pre-operative image. And many vendors provide this technique with software application that avoid the need to use specific implants. The infrared trackers, we see it in this picture, this infrared trackers used in which the computer hardware is linked to a camera, and this is the camera, and this camera will track the trackers and detect the position of the tracker and any instrument that has a tracker array fixed to it. Let us see the outcomes in literature. There is some studies and meta-analysis reviewed this technique, and they found that this technique has accuracy mechanical aligned primary total knee replacement comparing to conventional instrumentation. Comparative study of total knee replacement performed using navigation have not showed significant advantages in pain relief, function, or survivorship of the implants, comparing to total knee performed using the modern conventional instrumentation. Cost and the time is the main problem of this technique and the main disadvantage of this technique. The second technology is the robotic assisted knee replacement. The integration of robotic into knee arthroplasty procedures actually began in 2000s and has seen a wide scale adoption in the past several years. Robotic application are an extension of computer navigation and are part of a habitually enabled system approach to the knee surgery. Robotics integration, preoperative and intraoperative planning with computer modeling, and assist the surgeon in executing the surgical plan in a precise, efficient manner. The improved accuracy of the procedure with customization to the patient-specific pathology improves implant congruency, limb alignment, gap balance, and potential errors for failure and poor outcomes. The FDA clearance for the robotic application defines its specific use in knee arthroplasty in a unicompartmental, bicompartmental, and total knee replacement. The contraindication of the robotic is the same of contraindication for the conventional knee replacement. And the robotic, it's include three main systems: the active, semi-active, and the passive. The active system have a robotic arm, help the surgeon to perform a function as prescribed by the surgeon before. And currently there is no FDA approved robotic application in knee arthroplasty. With the semi-active system, the robot augments the surgeon's ability to control resection by guiding and physically contraining the surgeons with a three-dimensional space, but it does not autonomously perform the bone resection. With the passive system, the robot positions and cutting guide at a computer navigation, but does not constrain the surgeon. Integration of haptics has advanced and safety and efficiency the robotic knee surgery. Haptics is the science of applying touch or tactile sensation and control to interaction with the computer application, and may help the surgeon to do a precise, accurate cut by receiving a tactile sensation of the arm, physically resisting surgeon from applying force when the haptic boundaries is reached. Currently, two companies have systems used for unicompartmental and bicompartmental knee arthroplasty, and both systems use a semi-active robotic approach, one integrated image-based and one imageless. Regarding the clinical studies in literature for the robotic, it is very less, and there is some studies done in 2013. It is a randomized control study, and it showed that the cases done with robotic has a less pain in the first 8 weeks. And there is another study follow up about 701 robotic cases, and they found the revision rate is very less comparing to conventional one. This study used or compared the unicompartmental knee replacement, and there is no current studies on the total knee replacement. In summary, robotic has shown promising early result to minimize surgical errors that result in significant number of revisions and poor patient satisfaction. Further long-term studies are required to support the capital investment and sustained improvement in patient outcomes. The main disadvantage of this technique is the very high cost and also the time taken to apply this system and to start. But I think with time and with the learning curve increase with time and may improved with time. The last technology we will discuss tonight is the patient-specific cutting guides. This technology removes the intraoperative variability and time requirements by shifting the bony landmark registrations and implant positioning to the preoperative setting by doing CT and MRI preoperative. And after that, we will construct a three-dimensional model of the knee. This image is then used to determine the mechanical axis of the lower extremity, and the computer modeling software analyze this information and make a body tomography to create a virtual knee, a model that is used to calculate the proper size femoral and tibial component and the ideal component alignment and rotation. Once the preoperative plan is finalized, the exact bone resection are designed into the patient-specific cutting blocks to match the virtual bone. According to the studies, there is no actually significant difference between the patient-specific implants and the conventional total knee replacement for mechanical alignment and post-operative complications. The cost, of course, will be high, and the need of pre-operative CT scan and an MRI also will increase the cost. This is what was the first talk tonight, and if you allow me, I will go to my second talk, which is about the simultaneous bilateral knee replacement. I know this topic will create a lot of debate, and a lot of people would agree with me, and a lot of them may not agree with me. I will share with you our experience in Saudi German hospital. First, let us introduce the topic. The bilateral or simultaneous bilateral total knee replacement become a routine procedure doing in our hospital in SGH in Asir. And many patients with both knee osteoarthritis has the benefit of this surgery. We create a criteria to choose a right patient for this procedure, and we have to have a good teams and work together as orthopedic anesthesiologists, nurses, and physio to make this succeed and happen. The main advantages of this procedure is give less time of work off for the patient, less time spent in the hospital, less time in the physical therapy, and regain and maintain the physical activity level. And it is, of course, less cost comparing to staged bilateral total knee replacement. The main disadvantages is the more blood loss, the complication risk increase a little bit comparing to staged bilateral total knee replacement. Some of patients need to go to rehab center after the surgery. Sometimes take more time than the staged total knee replacement, and the patient will have no good leg to stand on and depend on. By going to literatures and reviewing the literatures, we will see that there is a debate, some with this procedure and some against it. Barfizi and colleagues between 1996 and 2005, they did a meta-analysis of 150 papers, and they found that this procedure have a high risk of increased pulmonary embolism and cardiac complications. Another meta-analysis done in 2011 found that the mortality is about 3.2% comparing to 1.7% in the staged total knee replacement. Skalko and colleagues studied 500 patients and they found no deaths, no strokes, no myocardial infarctions. And Skalko also studied the cost and he found it less with the simultaneous total knee replacement bilaterally. It's about 67,000 for the simultaneous total knee replacement bilaterally and $90,000 for the staged bilateral total knee replacement, and this is a huge difference. There is another study comparing the unilateral with the bilateral total knee replacement with 90 days morbidity and mortality, and they conclude that there is no significant difference between unilateral and bilateral total knee replacement in terms of mortality and morbidity, except for some cases they developed DVT, deep vein thrombosis. Another study, they study the complication associated with the staged versus the simultaneous bilateral total knee replacement, and they analysis of about more than 7,000 patients, and they found that the simultaneous total knee replacement is a higher rate of blood transfusion and readmission associated with higher rate of mechanical complication and infection associated with the staged bilateral knee replacement. Another paper from China, they compare the bilateral sequential total knee replacement with the unilateral, and they found that the bilateral sequential total knee replacement is a safe surgery in selected patient performed in high volume hospital with fast-tracked programs. Now let us see our experience in Saudi German hospital in Asir. We create a criteria to choose the patient for this surgery. The PMI has to be less than 35. The minimum arc of motion has to be 100% of flexion. No flexion contraction more than 20 degrees. No varus or valgus alignment less than 20 degrees. And no prior history of cardiovascular disease, and the age must be less than 75 years. Preoperatively, we send the patient to the anesthesia for consultation, cardiology, for echo and ECG. We'll do CBC, SAR, CRP, and INR, BT, BTT, kidney function disease, and the urine analysis to make sure there is no source of infection anywhere. Chest X-ray and ECG, and we have a group and safe of blood of about 2 units packed RBCs. During the surgery, we are using the epidural and spinal together. Follis catheter is inserted. We are using tourniquet, antibiotic, tranexamic acid, hydrocortisone at induction of the anesthesia. We are using 2 separate drapes. We are not doing it in the same time. We finished one side, then re-drape and go for the other leg. We are using the medial parapatellar approach. Of course, we are using wound drain, and we use the post-op ice band brace. Post-operatively, patient is taking antibiotic for about 3 days, Clexane 40 milligram for 15 days, hydrocortisone 100 milligram, another 2 doses, 8 hours apart. We are using the leg stocking. Physical therapies started in the same day. Wound drain removed after 24 hours. CBC after removing the drains. Follis catheter removed after 24 hours. Epidural catheter removed in the 3rd day post-op. We collected the data and numbers from June 2017. till the June 2020. We have 15 cases with one surgeon, only me, 11 females, 4 males. Duration of surgery totally is 3 hours. Blood loss is about 500 on average. Infection, we have only one case with the superficial infection presented in the 3rd week post-op and treated with debridement and irrigation. There is no cases with DVT or pulmonary embolism. The main stay in the hospital is about 5 days. Okay, at the end, it's get popular now, and a lot of patients came asking for the simultaneous bilateral total knee replacement. It's of course cost effective, but the secret to succeed in such cases is the good patient choose. I mean, you have to have a good criteria to choose the patient and select your patient. Not all or every patient is good for the surgery. Of course, you have a good team, organized team. If you are doing the unilateral total knee in 2 or 3 hours, you cannot, of course, do bilateral total knee at the same time. You have to be fast, efficient, and your team, of course, they have to be in symphony working with you. Thanks God, I'm lucky. I have a very good team in Saudi German hospital in Asir, and I wish we will be better in the future. Thank you very much for listening and for your time, and I will leave the chance for my colleagues. Thank you so much.
Thank you, Dr. Walid. I have received some of questions, but it's better if we make all the questions at the end of the webinar. Now I have Dr. Hani Al-Ashmawi. He's the senior registrar in Saudi German Hospital Asir. He will talk about the idiopathic scoliosis in adolescents. What does that mean? The curve of that, the clinical examination and the radiological examination regarding that, the indication and the timing for surgery, and finally the follow-up regarding that. Dr. Hani, the mic is yours.
Thank you, Dr. Marwan. Thank you, Dr. Walid, the head of the department, and our colleague. I will start my presentation. This case, 15 years old girl presented by this high degree spine deformity. 3 years earlier, we review her X-rays. We found that she had earlier mild deformity, which progressed to this moderate deformity after 2 years. So we faced this high degree spine deformity, which necessitates the correction, but we were fear about the complications of scoliosis surgery, which include neurologic deficit and dural tears, major blood loss, infection, early instrumentation failure, pseudoarthrosis, and post-operative trunk imbalance. Another case, 12 years old girl presented by this mild spine deformity, which progressed after 1 year to this major deformity. 11 years old girl presented by this deformity. We noticed that she is still immature, and she had still the cartilage open. After 1 year, she progressed to this major deformity, and the triradiate cartilage closed. 11 years old girl presented by this mild deformity. Still, the triradiate cartilage opened. After 2 years, she had this severe thoracic scoliosis, which of course affect her pulmonary function seen in this pulmonary function test. This raising the issue about progression of AIS or adolescent idiopathic scoliosis. As we all know, scoliosis is a complex deformity with this characteristic rib hump deformity resulted from vertebral rotation. Scoliosis may be idiopathic, congenital, neuromuscular. Deformity is caused by neurofibromatosis, mesenchymal disorders, post-traumatic, post-infection, post-tumors, and miscellaneous conditions in which spinal deformity is common. Among of these, AIS is the most common. It occurs after the age of 10 years. School screening programs have shown prevalence rate about 0.2 to 0.3% for curves exceeding 30%. In curves greater than 30%, female predominates by ratio of 10 to 1 to males. Etiology is multifactorial by two mechanisms, one for the initiation and another for the curve progression. Factors such as genetic, gross, biomechanical, and neuromuscular seem to be involved in the etiology of AIS. What about the consequence? Of course, it may lead to back pain, may affect the pulmonary function in severe cases, which may lead to mortality and psychological effect from the deformed spine and the curve progression. We can name the AIS as a 4D deformity. It occurs in 3 planes, coronal, sagittal, and the axial plane. With addition of time, it may be a 4D deformity. So the curve may increase with time. It may increase before skeletal maturity. Curve progression is defined as increase exceeding 5 degrees to 6 degrees over 6 months. This can be predicted by the following factors. The important and the first of all, the remaining gross potential, which can be assessed by the following maturity indices. First, the Reader sign. It is a radiographic measurement based on the ossification of iliac apophysis. As we see in the stage number 1, only 25 from the iliac apophysis is ossified, and the stage 5, all the iliac apophysis is ossified and fused with the ilium. In the earlier stages, stage 1 or 2, the risk of progression is 50%. When we pass stage 2, the risk is decreased to less than 20%. Menarchal status. Pre-menarchal girl is still in the active growth period. After menarche, the girl enters the deceleration phase of growth, and the risk of progression decreases. Menarche is a late event in puberty. Growth spurt begins 12 to 18 months prior to menarche. The risk of progression is approximately 50% before menarche, while this risk is reduced to less than 20% following menarche. Peak height velocity is defined as a growth rate of at least 9 centimeters per year as calculated by standing or sitting height at 6 months intervals for a minimum of 2.5 years. The timing of peak height velocity is known as the peak growth age. The peak height velocity accounts for maximal progression of the curve. Peak growth age is less than the age of menarche and Reader 1. Another important clinical maturity indices is the Tanner staging, which assesses breast and pubic hair development in girls and genital pubic hair development in boys. For girls, peak height velocity, which accounts for maximal curve progression, occurs in stage 1 and 2 and 3. While for boys, it occurs in stage 3 to 5. Another one is triradiate cartilage. As we see in this table, progression is much more, while the triradiate cartilage is still open, which it is decreased when the triradiate cartilage closed. Other factors, the age at diagnosis and curve severity, shown in this table. Curves between 5 to 90 degrees before the age of 10 years, the risk of progression is 45%. This decreased to less than 4% when the girl passed 15 years. For curves between 20 to 29 degrees, the curve risk of progression is maximum 100% when the girl is lower, less than 10 years. This decreased to 16% when it is past 15 years. Other factors, sex, of course, the girl is more risky for progression than males, and with positive female history. Also, curve pattern, thoracic curves have highest risk of progression. Also, vertebral rotation, curves with greatest degree of vertebral rotation seem to have a greater risk of progression. Also, spinal balance. Balanced spine is more prone to progress than imbalanced spine, as the proprioceptive system in growing patients who have imbalance may attempt to correct it, thus preventing further progression. Another maturity indices, another factor, predictive factors for curve progression is thrombocyte abnormality and calmodulin levels in the serum. Abnormalities in the function and structure of the thrombocyte may present in IES. Calmodulin is the calcium binding receptor protein, which regulates the contractility of platelets and muscles. High calmodulin levels may be a risk factor for progression of EIS. The curve may progress after skeletal maturity, but much slower than in adolescence and dependent on a curve size. This diagram illustrates the protocol of treatment of cases of EIS. We had observation, brace surgery, observation in a skeletally immature patient with curves less than 25 degrees can be reevaluated by standing posterior anterior X-ray every 6 months. Orthotic treatment for curves between 30 and 40 degrees in a skeletally immature patient, and if the curve is progressed beyond 5 to 6 degrees every 6 months. Protocol of brace treatment, it may be a full-time, which is more effective, or part-time. Evaluation of the deformity in the brace by a single standing without brace posterior anterior X-ray at 4 months interval for rapidly growing adolescents or in large curves at 6 months interval for those patients nearing maturity. I want to judge the success of brace treatment. Successful bracing is obtained if the curve is not progressed more than 5 degrees throughout the treatment period. I want to win the brace when the girl is approximately 18 to 24 months post-menarchal, reserve for, or when no further increase in her height has occurred. Surgery is indicated when the curves exceeding 45 degrees in immature patient and for curves greater than 50 degrees in mature patient. Of course, posterior correction and diffusion represent the gold standard of surgical treatment in EIS. The development of modern instrumentation for posterior instrumentation and the correction of cases of EIS began with Harrington system in 1950s. He designed this stainless steel rod and hook system, which was the gold standard for the treatment of cases of EIS, particularly for thoracic curves. In 1970s, Loki used a segmental instrumentation which consists of rods and sublaminar wiring. Cottrell Debussy in 1988 used a segmental system called Cottrell Debussy instrumentation, composed of multiple hooks and later pedicle screws allowing segmental fixation, translation of the curves, and restoration of normal sagittal contour by rod rotation. In 1994, Soquitel first treated case of IS using pedicle screws. All screw fixation allowed better three-dimensional correction of the deformity with minimal correction loss and decreased the risk of neurological injury. This is my cases. Unfortunately, I newly joined orthopedic department in Saudi German Hospital Asir. So this is my cases done in Egypt. This is a girl with this lumbar curve with the apex at disc between dorsal 12 and L1. This is after the correction, using all screw fixations with a nice correction. Another case was right thoracic curve, which corrected by this also all pedicle screws, leaving this minor lumbar curve. This is another case with high degree thoracic curve, treated also by all pedicle screws. This is another case with a right thoracic curve. We notice that this right shoulder is higher than the left and rib hump deformity. This is after the correction. The shoulder is leveled, the rib hump is decreased more or less, and the waistline is leveled with this nice correction. After surgery, there is any complication related to remaining growth, of course. It is a common complication, crankshaft phenomena or bending of the fusion mass. It means progressive spinal deformity results from continued anterior growth in the presence of solid posterior fusion. It occurs in when the surgery is done in children before the age of 10 years with laser sign 0 or still have open triradiate cartilage. To prevent this phenomena, we must prevent or arrest the remaining anterior growth potential. Finally, careful examination of cases of AIS clinically, including height, menarche, tunnel staging, and radiologically, including 4 basic film of the spine, plus pelvis EB film for laser staging and triradiate cartilage. This gives us idea about the remaining cross potential, which affect the curve of progression. What about the indications and timing for surgeries? Follow up during the bracing, be careful to decrease the risk of complication. Thank you.
Thank you, Dr. Hani. Thank you, Dr. Hani. Now we have Dr. Walid Hamid, our orthopedic registrar, Saudi German Hospital. We will talk about the pathological fractures in the long bone, the common cause for the pathological fractures, how to differentiate between the pathological and the traumatic fractures, the pathway in the diagnostic, and the management. Now, Dr. Walid.
Thank you, Dr. Marwan. It's really a great time to share with our audience and also with our colleagues in Saudi German Hospital this topic. Really, this topic is a very big topic, and I will try to summarize the most of the important items that I will emphasize on. What is the definition of pathological fracture? We can say this is a pathological fracture that this fracture occurs in abnormal bone. This weakened bone failure during normal activity or after minor trauma. The pathological fracture usually forms poor, callous, and with delayed or no healing. This fracture needs special attention for diagnosis and management. Also, it can cause morbidity and mortality if treated as traumatic fracture. We have many different causes of pathological fractures, and mainly any orthopedic disease or most of orthopedic disease can cause pathological fractures. And classification can be classified as pathological fracture in young versus adult. These causes can be systemic or localized. Other causes also benign or malignant, and there's also correctable causes and uncorrectable causes. In the young patient, mainly benign tumors and tumor-like conditions like non-ossified fibroma, and also malignant tumor can be found in young patients like osteosarcoma and Ewing sarcoma. Also rickets and connective tissue disease like osteogenesis imperfecta. In adult population, osteoporosis is the main cause of pathological fracture in adults seen nowadays. Also, other causes include hyperparathyroidism, osteomalacia, osteomyelitis, Paget disease, osteopetrosis, and of course, benign tumors, primary malignant bone tumors, and this metastatic malignant bone tumor. This is the second most common cause in adults. If we need to do a classification by another mean, can be classified as developmental disorder of bone, nutritional and vitamin deficiency. Pathological fracture can be due to hormonal imbalance or atrophic conditions of bones. Can occur also pathological fracture in infected bone like in osteomyelitis or in cystic or fibrous bone disease, as mentioned before. Paget disease and primary bone tumors, and also malignant tumor and metastatic tumor of bone. Also, causes of pathological fracture can include the marrow cell disorder, parasitic disease, neurotrophic dystrophy of bone, and there's also topic of iatrogenic pathological fracture. This can happen through screw holes after removal or after fixation, or through biopsy of bone, or after removal of infected bone, or at the donor site for a bone graft. Also common nowadays that drugs that causing osteoporosis, and of course osteoporosis will cause pathological fracture, like the use of steroids. For the diagnostic approach, it is the most important step for the diagnosis of these fractures, as this is the pathway we can follow to differentiate and to know this is a pathological fracture, as this is totally different in management than ordinary traumatic fracture. So the clinical history and examination need to reach an etiological diagnosis. You should reach an etiology. The history should include the age, the history of previous fracture, the history of known medical disorder, and of course, the history of malignancy. Also, we need to know the dietary history, the drug history, history of addiction or smoking or alcohol intake, and also family history of disease that can cause pathological fracture. When I'm taking the history from the patient, there's some factors that suggest this is a pathological fracture, and I should know this well, because this factor happen if there's a spontaneous fracture, or this fracture occur after a minor trauma, or if there's pain at the site before the fracture, or there's multiple recent fracture happen to the patient, or unusual fracture pattern like a banana-shaped fracture that is transverse break in the bone, and also if the patient is older than 45 years, and if there's history of primary malignancy. Examination, I should examine all the body, so systematic examination, and to find a cause for this pathological fracture. There is a big list of investigations, of course, so we will not do all this investigation, but according to the history and the examination, we can go through specific tests to find out the diagnosis or the cause of this pathological fracture. And also we should know the causes that produce osteopenia, like osteoporosis, osteomalacia, hyperparathyroidism, renal osteodystrophy, Paget disease of bone, and myeloma. This is the most common causes of causing bone osteopenia. And for the aid, the diagnosis, of course, we need to do some radiological investigations. This includes chest X-ray, CT scan of the thorax and the lung for carcinoma. We can do also abdominal sonography for abdominal malignancy or for kidney disease. We can do skeletal survey for fracture in bone cyst or osteolytic or osteosclerotic lesions. We can use the double energy X-ray absorptiometry scan for the 3 sites in the body to detect low bone mineral density. We can use PET scan for occult malignancy or malignancy of unknown origin, and also MRI can be used for spinal metastasis, other spinal metastasis detected. Of course, we need to do histopathology. This can be done by CT-guided fine needle aspiration cytology, and also by open bone biopsy. We will talk mainly today for some types of pathological fractures in adults. In children, it is a very big topic. We didn't mention here in this topic. Mainly the causes in adults will be tumors and metabolic causes. The tumors may be primary, which can be benign or malignant tumors. This is the primary, and it can be secondary or metastatic. This is most common than primary, of course. For the metabolic causes, we have osteoporosis, and this is the most common of all pathological fracture cause. And we have Paget disease and hyperparathyroidism. For the osteoporotic fractures, this is the most frequent cause of pathological fracture. And in men, it arises in the ribs, spine, and the wrist. Where in women, it is common. These fractures are common. Sites include the wrist, spine, ribs, humerus, and femur. In the elderly, the rising incidence of proximal fracture of the femur represents the most important socioeconomic impact of osteoporosis. And in 2000, there were approximately 24,000 hip fracture worldwide in men, and more than 1 million in women. This based on the demographic and the increase in life expectancy. It is estimated that by 2025 there will be an increase of 89% in men, resulting in 800,000 hip fracture per year in men, and in women the number will rise by 69% to be 1.8 million. The problem in osteoporotic fracture is the healing of bone in osteoporotic fracture pass through the normal stage, but with the union of fracture, although the healing process is very prolonged, and there is high rate of complications and incidence of implant failure. In the clinical settings, there is common osteoporotic fracture which may give rise to difficulties with treatment, include fracture of the proximal humerus, distal areas, proximal and distal femur, and spine. And these are the most common sites for pathological fractures in osteoporotic patients that may cause morbidity and even mortality for the patient. This diagram for the pathway for the management of osteoporotic fragments. We mainly here notice that with surgical treatment, we may need to use joint replacement or fixation. The fixation principle, we can use wide buttress principle, we can use augmentation or impaction. We can use lever arm modifications. We can use nails, locking plate, K-wires, and external fixators. The second cause we will mention for osteoporotic fracture is hyperparathyroidism. Hyperparathyroidism can be primary, secondary, or tertiary. Mainly primary due to adenoma, will be polycystic disease, and there will be mental status change and abdominal pain, nephrolysis, and polycystic disease. There is mixed radiolucent and radiodense opacities like we see in this X-ray. Hyperparathyroidism may be secondary to renal failure, and this picture is common to be seen due to renal failure, which can be secondary or tertiary, and the treatment will be with parathyroid adenectomy or relief of the fracture and correction of calcium, of course. And this picture showing the pathological fracture through brown tumor. This brown tumor is caused by hyperparathyroidism. The other cause is Paget disease. There is thickened cortices in Paget disease, and there is purposeful trabecula, and there is mixed scoliosis and lysis, and there is bowing deformity and joint arthrosis. For the fracture in Paget disease, there is delayed healing and maybe malignant transformation. The treatment may include osteotomy to correct alignment and and there is excessive bleeding noticed with surgery, and we can use joint arthroplasty versus OE for the fracture. We will continue for the pathological fracture causes. We will speak about benign tumors. These fractures in benign tumors are more common than in malignant tumors, and most benign tumors are asymptomatic prior to fracture. Antecedent nocturnal arrest symptoms are rare, and this is most common in children, this benign tumors for the humerus and femur, but of course it can also occur in adults. And this causes like unicameral bone cyst, non-ossifying fibroma, fibrous dysplasia, eosinophilic granuloma, giant cell tumor, and aneurysmal bone cyst. This is the most common causes of benign tumors. We will speak here about this entities come mainly in adult, or this is a giant cell tumor. This fracture, as you see here, this is through a giant cell tumor. But this giant cell tumor is aggressive tumor, and therapy may be by radiotherapy alone for inoperable lesion. Denosumab or bisphosphonates can be used to stabilize the lesion and to reduce the size. For the operative treatment, this needs extensive curettage and adjuvant treatment. Pathological fracture in large periarticular lesions. If we have a large periarticular lesion like this one, we could suspect a pathological fracture to happen in this. This topic of atypical femur fracture is seen commonly nowadays, and it has many debates and still deficient data to judge his treatment. But we will speak shortly about it. This is one of the potential complications of prolonged bisphosphonate therapy for the treatment of osteoporosis, and has reasonable concern in the recent years. The evidence of association between bisphosphonate use and atypical femur fracture is strong, and the incidence of atypical femur fractures among patients taking bisphosphonates for over 10 years can be as high as 107.5 over 100,000 persons per year. This criteria for this atypical femur fracture was happened lower than the lesser trochanter or the supracondylar flare. There is minimal or no trauma. This fracture is mostly transverse or short oblique configuration. It is not convoluted and involve both cortices. Atypical femur fractures, there was In 2014, the task force report reviews the clinical dates published and suggested treatment recommendation for patients with a typical femur fracture to discontinue bisphosphonate therapy once the diagnosis is established of a typical femur fracture, and reassess the initiation of calcium and vitamin D treatment. And also we can conduct a prophylactic intramedullary nail operation for patients with incomplete fracture. This is very, very important, who are suffering from pain, and to undertake the conservative therapy for patients with incomplete fracture who are suffering from mild pain or are without pain. Intramedullary nails must be conducted if there is no radiologic or symptom improvement during the 2 to 3 months of conservative therapy because of the possible progression to complete fractures. We will speak about a very important topic now, is the pathological fracture through primary malignant bone tumors. This is relatively rare, often unsuspected, may occur prior to or during treatment, and may occur later in patients with radiation from osteonecrosis, like cases of Ewing sarcoma or lymphoma. Also with osteosarcoma and Ewing malignant fibrocytoma and fibrosarcoma. You should suspect primary tumor in young patients with aggressive appearing lesions. This can be poorly defined margins with wide zone of transmission and lack of sclerotic rim. These lesions are matrix producing and there is periosteal reaction. This patient usually have antecedent pain before fracture, especially night pain. For pathological fracture complicates but doesn't mitigate against limb salvage. Before, in the past, this pathological fracture happened in a primary malignant bone tumor. Amputation was the only solution for this, but now there is good result with limb salvage procedures. But local recurrence is higher and survival is not compromising. Patient with fracture and underlying suspicion lesion or history should be referred for biopsy. And if you suspect, the message here, if you suspect a primary bone tumor and the fracture, pathological fracture through it, don't hurry to fix it. You should have a biopsy first, and you should, of course, ensure work team with orthopedic oncologist to share the diagnosis and the management of this patient, but don't hurry to fix this patient. Always biopsy solitary destructive bone lesion, even with a history of primary carcinoma. And if you know that this patient have a carcinoma before, like breast cancer, don't say that this is a metastasis, I should fix it. No, you should go through biopsy and oncology opinion. This is a picture of intermediate grade osteochondrosarcoma. This pathological fracture through it, and it is fixed by cephalomedullary interlocking nail. The treatment for primary malignant tumor include the immobilization, maybe interaction or external fixator or cast. Then we will do staging, biopsy. This patient can use also adjuvant treatment like chemotherapy, and surgery can be done later after that, like a section reconstruction or amputation. About the metastatic disease and myeloma, this is the most common of the tumors. Can happen in the 5th decade. Appendicular sites like the femur, humerus, and are most common. But all metastatic tumors are not treated the same, because metastatic bone disease from the breast, lung, kidney, prostate, thyroid, and hematologic malignancy include multiple myeloma, are common causes of pathological fractures. The fractures that are pathologic result from the involvement of bone by metastatic tumor are biologically different from fracture that result from non-neoplastic conditions such as trauma. And this is the most important differentiation, and this will affect the management. Therefore, the treatment principle for pathologic fracture result from neoplastic cause differ from those for fracture result from trauma. The assumption that pathologic fracture result from neoplasm can be treated in a similar fashion to non-pathologic fracture often produce a less than satisfactory result for the patient with a neoplastic pathologic fracture. Moreover, this is very important. The goal of treating a fracture of traumatic origin is to maximize the potential for fracture healing. I need healing in traumatic fracture, and minimize the complication. But the goal for treatment pathologic fracture is to retain this from metastasis or from malignancy is to retain the patient as rapidly as possible to maximal function, which may or may not result in fracture healing. So fracture healing, I am not aiming for in this type of pathological fracture. We can say that not all myths created equal because breast metastasis is radiosensitive and chemosensitive. Lung is moderately radiosensitive and chemosensitive. Also, prostate is radiosensitive and chemosensitive. Thyroid is radiosensitive and chemosensitive. Renal metastasis minimally radiosensitive and variable chemosensitivity. And these differences will affect the line of management. The incidence of metastasis 60% of patients with early identified cancer and may already have metastasis. 10 to 15% of all patients with primary carcinoma will have radiologic evidence of bone metastasis during the course of the disease. This is the most common primary site as there is the incidence of metastasis. As we can see here from the breast is most common, and the prostate Hodgkin lymphoma. Metastasis of bone can occur by two routes, as a contiguous route or hematogenous. This is the most common, the hematogenous spread of metastasis. And the mechanism of metastasis with the release of cell from the primary tumor. Invasion happened for the lymphatic or vascular channel with dissemination of cell endothelial attachment and invasion at distant sites. The bone destruction that happens with metastasis can be early or late. The early bone destruction is the most important. This is osteoclast mediated, so rank L, and late with the malignant cell may be directly responsible. It is also metastatic lesion of unknown origin. This is 3 to 4% of all carcinoma. Now we will go to the how to diagnose and evaluate. This is very important and the common topic nowadays. For the successful management, the following ads should be followed. I should stop when I see a pathological fracture, so this. Then I should think, stage, and then act. And there is important 4 questions to be gathered from the patient about what is the origin of the lesion, and what is the dissemination status, and what is the general health of the patient, and what is the local status of the involved bone. About the origin of the patient, if we have a bone lesion with a known etiology, is a primary bone tumor until proven otherwise. Denying this possibility might deprive patient of correct and curative treatment. If the patient have no history of malignancy, a PET scan of the chest can be done and the abdomen should be performed. In case there is no primary tumor is visible, a core needle biopsy of the bone lesion should be performed for histological identification before treatment is engaged. When the patient has already known malignancy but has no previous metastasis and the lesion is solitary, a biopsy should be considered. And in case of multiple lesion and malignancy at high risk for developing metastasis like lung cancer, no additional histological confirmation like biopsy is necessary. The second question is what is the dissemination status of the lesion? The bone dissemination can be 3 categories: solitary, oligometastasis, and or diffuse. Solitary lesion can, in some cases, such as primary kidney cancer or bone sarcoma, can be treated with curative or palliative. More aggressive local treatment in case of oligometastasis might improve the survival. We need to also know the general health of the patient before management can be deducted from the patient history about the nutrition, the weight, the cognitive status. We need to know the hydration status, and if surgery is planned, the laboratory studies should include a complete differential blood cell count and other blood investigation. We need to know also the fourth question, what is the local status of the involved bone? This can be by X-ray or CT scan can be used also. And the information gathered can stand the workup, provides the basis for staging of patient and determining the treatment strategy. And in the treatment, we should adhere to two important principles. That prophylactic stabilization of bone should be performed if there is a substantial risk of fracture, and the selected rigid fixation should be durable for the remaining lifetime of the patient, while the recovery and rehabilitation time should not exceed the life expectancy of the patient. There is also cortical defect that weakens the bone, especially in torsion. This can be of two types, either stress riser or open section defect that causes fracture. And for impending pathological fracture, this may consume about 61% of all pathologic fracture, and 80% are vertebrocanteric fracture. There is some indications for the prophylactic internal fixation. There is Harrington criteria, and also there is a Merrill scoring system. This according to the site and the pain and the lesion and the size of the lesion. If the criteria of the score is more than 7, so I should do prophylactic fixation. This is Merrill criteria, and this is common sites for pathological fracture. And this is a fixation method that can be used for pathological fracture. For the prophylactic fixation, it has some advantages that it is decreased morbidity, decreased hospital stay, and easier rehabilitation. And it can cause more immediate pain relief, faster surgery, and less complication. There's less blood loss, of course. There's some risk like fixation device failure and loss of fixation. This is guidance to perform the biopsy for lytic lesions. And we will go for the treatment object in metastatic disease. The objective of treatment in metastatic disease with fracture to decrease pain and restore function and restore mobility or limit surgical procedure or minimize hospital time and early return to function by immediate weight bearing. So the treatment, we should emphasize on biopsy, especially for solitary lesions. And if we have only solitary lesion, we should have biopsy first. We should use nails versus blades versus arthroplasty. We can use also cement augmentation, radiation therapy, chemotherapy, and bisphosphonates have a role also in treatment of this fracture of metastasis. And we should use aggressive rehabilitation. The indication for surgical treatment is that the ratio of survival time to surgical recovery time, the ability to ambulate, the patient ability to ambulate, the ability to use his extremities, and the capacity of the patient to return to full function, and the pain not controlled by analgesic, and location of the disease like high risk areas like in the proximal femur. We can use intermedullary nails or blades for the physical lesions, and if there is good bone stock, and the histology is sensitive to chemo or radiotherapy, and if there is impending fracture or poor prosthetic option. The other option, we can use joint replacement if this fracture is very articular, or if the fracture happened after radiation, or if failed fixation, and also with renal cell carcinoma because this curative. Cement is better for use with these fractures. And this is a different fixation option like cephalomodular nails, hip prosthesis, custom-made prosthesis, knee custom-made prosthesis. This one in the tibia, fixation options. The distal tibia, we can use radiotherapy. We can do a section for pathologic fracture and impending pathological fracture. This for radiation and chemotherapy-resistant tumors like renal, thyroid, melanoma, and occasional lung, or if it is solitary metastasis, we can use also embolization for hypervascular tumors like renal cell carcinoma. There's some complication like infection, hemorrhage, tumor recurrence, failure of fixation, and thromboembolic disease. For conclusion, the etiological diagnosis of pathological fracture is a real clinical challenge to physicians. It has varied clinical presentation, etiology, and prognosis. So history and the clinical examination are needed for judicious choice of investigations. Sometimes extensive investigations are required to arrive at a diagnosis. The proper etiological diagnosis and treatment of underlying disorder is the key to the successful management of pathological fracture, and this is very important. Diagnosis and treatment requires a multidisciplinary approach with the team and orthopedic oncologist. Aggressive surgical treatment relieve pain and restore function and facilitate nursing care. Do biopsy for all solitary lesion or refer to oncologist, and understand the tumor biology and tailor the treatment. Thank you.
Thank you, Dr. Walid Hamid. I received a couple of questions for Dr. Walid Shafi. Dr. Walid Shafi.
هاي دكتور مروان معك.
Yeah. The first question I received, why you are using hydrocortisone in your protocol? I have a couple of questions, but I will give you 3 questions, Dr. Walid Shafi. The first question, why you are using hydrocortisone in your protocol?
Okay. Many studies in literatures prove that hydrocortisone will reduce the level of interleukin 6, and interleukin 6 and other factors play very strong effect in increasing the clots and developing the pulmonary embolism and DVT. For this reason, we are using a low dose of hydrocortisone, 100 milligram, 2 hours before the surgery, and 2 other doses post of the surgery to lower the risks of pulmonary embolism and DVT.
Okay. Also, I have a question. How can you avoid the complication in stimulus bilateral TKR? This one question. How can you avoid the complication? He's asking the complication is high. How can I avoid this complication?
Number one, and the gold standard is the patient selection. Not every patient is prone for simultaneous total knee replacement. You have be very strict in selecting your patient. You have to develop criteria. There is a lot of hospitals, they have their own criteria for this procedure. For me, I'm selecting the more fit patient. Most important, the BMI is less than 35. He's not older than 75, not having a lot of comorbidity like hypertensive and diabetic together, or hypertensive and cardiac. He's not taking more than 1 anticoagulant, and the deformity is not too severe. This is the main points I'm putting it when I choose the patient for simultaneous bilateral total knee replacement. The other factor is
what about the nutritional status of the patient? You didn't include in the criteria for the selection, the nutritional status.
What do you mean, yeah, doctor?
Nutritional status of the patient, like patient having severe anemia or
of course, anemia will affect
malnourished.
Malnourished anemia will affect the oxygenation of the blood, and this will increase the risk of DVT and pulmonary embolism. I'm avoiding patient with anemia and malnourished patient. The other important factors is your team in the hospital. You have to have a team knowledge and they have experience with such cases, and also the surgeon himself. The surgeon, he has to be have a good experience, and he's also fast in doing the knee replacement. Like if you are doing total knee replacement in 3 hours, you cannot do simultaneous bilateral in 6 hours. This will cause harm to the patient if you are putting him in under anesthesia for 6 hours. Also, the other team like anesthesiologist, physiotherapist, nurses, you have to develop a team. You have to sit with the others and make sure everything is doing efficiently and in a good time.
Also, Dr. Walid, there's one question. Did you publish your data? Is this published?
We are now collecting. Still, we are collecting and following our patients because we are starting in June 2017. We need to follow our patient more, and inshallah we will publish this data soon, inshallah, in a good paper, inshallah.
Inshallah. Thank you, Dr. Walid. Dr. Hani, I have question for Dr. Hani. How can to decrease the neurological complication during the pedicle screws? This question is for Dr. Hani. Dr. Hani? I think we have some issues with Dr. Hani.
Dr. Marwan, repeat the question, please.
I have one question. How can you decrease the neurological complication during the pedicle screws? He's asking about to decrease the neurological complication regarding the pedicle screws.
Many surgeons fear about putting screws in deformed spine. Screw fixation has many advantages over sublaminar wires and hook screws, but the issue, the complication while putting the screws. We can minimize this complication by careful preoperative planning, such as X-ray and CT, careful reading of the X-ray and CT to see the pedicles, dimensions, orientations. Also, we can use image-guided fixation by using X-ray or even CT if it is present in the hospital. We can also check the canal by doing limited laminectomy or laminotomy to feel the pedicle from inside the canal and to direct the screw, especially for the concave side application of the screws. After we put the rod on the concave side and do the correction, we do walk-up test for the patient to ensure that the spinal cord is free after the correction. This test is very, very essential to ensure that you are safe after the correction and putting the screws. Of course, if it is present in your hospital, use neuromonitoring to monitor your cord while you're putting the screws and while the correction. If the complications occur, please check the position of the screws by radiology, X-ray in the OR, or even CT outside the OR.
remove the screw. You suspect that it is the cause of the injury. Remove the rods, relieve the correction, and give corticosteroid, ensure the blood pressure and hemoglobin. And when the status of the cord become good, put a rod again or postpone it after 1 week or 2 weeks. Wait for the cord to recover.
Okay, Dr. Hani, also there is one question. Are you using the rod rotation or the direct vertebral rotation? This one, I think you're asking about the technique, Dr. Hani.
In our technique, we use rod rotation technique in all cases. You see that this is all the cases in our hospital in Egypt. We don't have still the system of direct vertebral rotation or DVR. So we use rod rotation technique. After contouring the rod on the to the desired sagittal profile, you put the rod on the concave side first and applying the knot loosely, and your assistant push on the concave side while you rotate the rod on the concave side to convert the coronal deformity to your desired sagittal profile. This is what we know rod rotation technique.
Also, Dr. Hani, is your case need thoracoplasty?
This is the advantage of using all pedicle screw in treating cases of AIS. It minimizes the use or doing thoracoplasty because you can rotate the spine safely. The screw is inside the 3 column of the spine. So the need for thoracoplasty with the use of all pedicle screws is lower. In our cases, only 2 cases we did for them thoracoplasty with higher cope angle and severe vertebral rotation. We did thoracoplasty on the convex side by removing not more than 4 reps from the convex side. Only 2 cases from about 70 cases till now.
Okay, thank you, Dr. Hani.
Thank you.
Dr. Walid Hamid, I have 2 questions for Dr. Walid Hamid. The first question is someone is asking about in case of bedridden post-brain injury, he's in the decorticating position for years, and patient develop humerus fracture. How can you treat this one? Is the decorticating position cause humerus fracture, and how can you treat? This for Dr. Walid Hamid.
As we mentioned, we should consider the patient state and his condition in the management of such a pathological fracture. About this case, this patient may have some pain or don't have pain with that fracture. This is the first question. The second question, if this patient nursing is easy or difficult, this will guide the management, and this is, as I told, a multidisciplinary approach. Not all patients need to be fixed, and also not all patients need to be left without surgical management. But according to that situation, this patient may need to do minimal surgery if he has good longevity to facilitate nursing, I think.
Okay. The other question is asking about the relation between the age and the post-traumatic bone injury. What's the relation between the age and the traumatic bone injury?
The age and traumatic bone injury, or pathologic bone injury. You need traumatic bone injury or pathologic bone injury with age?
He's asking about the traumatic.
The traumatic, we should suspect the age in the traumatic populations, like in the children, we should suspect some more common fractures. and according to the speed of the fracture or the trauma itself. So children have different pattern of fractures. In old age, we can suspect osteoporotic fracture, and usually osteoporotic fractures have minimal trauma in old age. But this doesn't mean if he has a severe trauma, of course, he can be injured also. So the age will guide us for traumatic injuries, about the fracture pattern, about the indication of fixation, surgery, or conservative treatment. And of course, in children, we will go more through the conservative management for different types of fractures that can't be done conservative in adult population.
Okay, thank you, Dr. Walid Hamid. I
شكرا.
think this is the end of the webinar. At the end, I would like to thank Dr. Walid Shafi. He's our orthopedic consultant and chairman for this webinar. Also, I would like to thank Dr. Hani, senior orthopedic registrar, and Dr. Walid Hamid is orthopedic registrar. Also, I would like to thank everyone who attended our webinar today. And I would like to remind all of the attend that the certificate will be given after fill up the online feedback form. Also, I would like to thank Saudi German Hospital for making this webinar possible, and for شركة المفصل, this المفصل company for sponsoring this one. At the end also, we hope you enjoy